You're on. Take it away.
All right. Good afternoon, everybody. It's great to be here and have a frank conversation about prostate cancer. I'm Dr. Arpit Rao. I'm a faculty member and a bona fide prostate cancer specialist at the University of Minnesota. And it's my absolute pleasure to spend this afternoon, or at least a part of it, with everybody in the group. We're still getting oriented to this platform, so I can't necessarily see your names or get a better sense of the audience, which it would have been amazing to do this in person. But I'm hoping that the content and the conversation today brings some value to your lives and makes you or helps you learn about some of the nuances and some of the basics of prostate cancer that may be applicable for you. So I think we can get started. I'm trying to see if there's any way I can look at the audience, but I guess that's okay. We can get.
You should have a board of, down at the bottom it says participants, so you can see people's names. I can also keep track of that. If somebody has a question, they can raise their hand. If you're okay with
Excellent.
You, are you okay with that?
Yeah, Annie, that works totally fine. Okay. Yeah. All right. So I think I can see that. All right, great. All right. So let's go and get started. Just a quick disclaimer, this is informational use only. We've tried to vet the content, but this doesn't substitute for a formal medical opinion or medical advice. It may seem like a lot, but we'll cover these topics today. We'll talk about what prostate cancer really means and how do you go about diagnosing it? Why is it important to get diagnosed? I mean, it may seem like an obvious question, but for many men, prostate cancer may actually never cause them harm. And going about the process of diagnosis may actually be harmful in many ways. And then we'll go over what it means to have prostate cancer, what staging means, and what treatment options one may have available. It's also important not all of the treatment options may be relevant to your situation. And again, that goes back to the point of listen to this conversation, listen to this talk, but always make the decisions about your care in conversation with your physicians. And so we'll go over how your healthcare team can make sense of this. What are some of the resources? You know, you're not fighting this alone. Prostate cancer is really common, and how you can leverage the community around you, your support system, your healthcare team, local resources, regional resources, and then national resources that are all trying to make your life a little bit better one day at a time. And then we'll open it up to the group to talk about if they have any questions. And then you get a chance to grade me on a curve. All right, so and at any point, if you have questions, please go ahead and ask. And if it's too fast, if the information's too much, just let us know. So what is cancer, and what is prostate cancer in particular? We define cancer as an abnormal growth of any type of cell in the human body. And so when our body does a remarkable job. You know, we have so many, trillions of cells in our body, and it's said every, I believe, 100 days or so, many of the entire cells of our certain parts of our body turn around, and there are new cells formed. So the human body is making new cells all the time. But when those new cells get formed, they stop growing if there's overcrowding, if there's not enough nutrition. The cancer cells tend to ignore all that, and they grow, they divide, they go from the organ they started in and they spread to different organs, and that's really what makes a cancer the way it is. And so naturally, prostate cancer is a cancer that starts within the prostate gland. And this figure should give you a sense of where that sits. So this is a man's pelvis, and deep within the pelvis and right below the urinary bladder, which is, let me show you if I can with this pointer. This is the bladder. This bladder's role is to store urine, and then the urine comes out through this urethra and out through the penis, and right under the bladder, this walnut-shaped and walnut-sized organ sits right behind your pubic bone, so in the middle of your body, and it sits right in front of the rectum. And that's it. This is the gland where the cancer starts, and this is what we'll talk about. Prostate does a lot of things for a normal, in a regular guy, and the main job is to give fluid that goes into the semen and help with reproductive function. So we talked about what prostate cancer is, but again, any symptom that may arise from prostate cancer can also arise from other things like inflammation of the prostate gland or enlargement of the prostate gland. So this may seem like a needless question. When you have cancer, you should care about it, but let's talk about why. 1 in 7 men in the United States will be diagnosed with prostate cancer in their lifetime. So that's a pretty serious odds of getting a cancer diagnosis in one's lifetime. I think there was a radio show a couple of days ago that I was listening to, and they said 1 in 100 men in Minnesota today has a diagnosis of prostate cancer, and that's huge. And that's like everybody. That's anybody who's 20 years of age versus 100 years of age. But if you look at everybody with gray hair, that proportion goes up significantly. So if you walk out that door today, you may run into somebody with a prostate cancer diagnosis who you never known before. And that incidence or that prevalence that is even higher in African-American men. It's even higher if you have a family history of prostate cancer. And this is going back to my original point, is you're not alone. If you are a guy who got diagnosed with prostate cancer, you're not even close to being alone. There's a huge number of men, unfortunately, who will share that diagnosis, but also there's a huge community of people who can support you. And about 3 million men are currently what we call survivors. So they carry a diagnosis of prostate cancer. It's an important reminder, if you are an African-American gentleman, or if you have a close family history of prostate cancer, then you're at the highest risk of developing it. So let's talk about what it may look like if one has prostate cancer. What symptoms could it come with? It's important to remember, and many men who come to my clinic for the first time, they're really surprised that they have prostate cancer, and they're really surprised that it may have spread and it's not caused any symptom whatsoever. And that's actually very true. I mean, it's a small organ. It may, and cancer may not cause any symptoms. When the cancer bulks up the prostate gland, it compresses that tube that passes in the middle of the gland and carries the urine. So that's why folks can have problems urinating. You may not be able to empty your bladder. You may have to go again and again, many times through the day. It may interrupt your meetings. It may interrupt your lifestyle. It may interrupt your sleep if you have to go over and over through the night. When you go, it may be weak urine stream, because the gland is still pressing down hard on that tube that's carrying the urine. So any of these symptoms can occur. And remember, these are non-specific. if your prostate is big because of, benign growth, which is BPH, or an infection or inflammation, that could cause the same kind of symptoms. So it's important to get checked out. If the cancer spreads, it can cause symptoms associated with spread. For example, dull pain in the pelvic area, or pain in the hips or the spine, if it goes to the bones, or loss of appetite, fatigue, if it goes and becomes widespread. So important things to keep in mind. So it may already be, as I said, quite late by the time you get symptoms from prostate cancer. And so the question is for us as a community is, how do we catch it early? And so screening is a process where we take a large group of asymptomatic people or people without any symptoms and do a certain test to catch the cancer early. That's what screening means. It's really, prostate cancer screening has had its ups and downs, and it's at times been very controversial, not because it doesn't help people, but it can cause harm to people who don't necessarily have prostate cancer, and that's the reason why. So possible benefits, if everything checks out, you may feel a little bit more comfortable. All of the tests coming back normal doesn't mean you have zero chance of prostate cancer, but it definitely means you have lower chance. Screening may help find cancer before it spreads to other parts of the body. And early cancer treatment may be initiated, and that may improve the rates of cure. It may decrease the complications with cancer spread. Anything that you can do to early diagnose the cancer or treat the cancer comes with the risks of the treatments or the screening tests themselves. So you may have what's called a false positive test where, hey, your PSA is high, we should do a biopsy, but it turns out that your PSA was high because of inflammation of the prostate rather than a true cancer. And so you got that biopsy, you may have had some side effects from the biopsy without actually needing one in the first place. So that's what a false positive looks like. And sometimes, as I said, the PSA may be normal, the biopsy may be negative, and then you still may be harboring a cancer. So that's a false negative. And even if we get a diagnosis of prostate cancer, it may actually not mean anything for you. There are plenty of 70-year-olds out there who are going to have no problems whatsoever for their lifetime with a diagnosis of prostate cancer, because it may just be a slow-growing cancer. So this busy slide, and I'll summarize this for you. There's been a lot of discussion about what's the best age range, who's the best kind of person to screen for prostate cancer. Right now, this is kind of the suggested range of 55 to 69 for somebody with average risk of prostate cancer. So if you're not an African-American gentleman, no family history of prostate cancer, or no history, personal or family history of a specific kind of gene problem, then you should consider getting screened in that age range. Any older, and it may actually not benefit you. Any younger, and you probably have too low of a chance of actually having prostate cancer. If you are in a higher risk, which is all of the other group of people that I just mentioned, then you may want to start screening sooner. This is my caveat. These guidelines can actually change quite rapidly and unpredictably sometimes. So every year or so, you should talk to your doctor and see if there are any updates for you, especially if you belong to that age range. We just talked about the symptoms. So let's, this is a way to actually quantify, meaning measure your symptoms and how severe they are. American Urologic Association, or AUA, has put together this list of 7 symptoms that are important to assess how badly your urine function is affected. And so you don't have to read this, but there is a way to measure how bad things are for you. And that calculator is available on various websites, but this is the one that I would think is it does an easy job, because this website, you can calculate your score and then send it to your email so that you can track it long term. And you can go back every few months, every year, and check if your score's gotten worse. All right, so we talked about who should get screened, what screening actually is. Let's talk about how screening is done. So there are a number of different ways we can do screening, and one's not necessarily better than another, but they all actually are used in combination to answer a difficult question of should you get screened. And so PSA test is a blood test. It's where you do a simple blood draw and you check for a chemical that's made by normal prostate cells and prostate cancer cells. And there are different ways to figure out if the PSA is really high. Sometimes if your PSA is a bit abnormal, your doctor may want to do another check in a few weeks to make sure it's really staying abnormal. And in that case, you may be directed to getting a biopsy. Additional rectal exam, as I mentioned before, the prostate gland sits right in front of the rectum. So there is a way you can feel how abnormal the prostate is, and you can feel if it's become big in size. And so this is a simple kind of in the office test that a physician or a provider can perform to look for your prostate size. If one or either of them or both of them come back abnormal, you may be recommended to go see a urologist who will do a biopsy to figure out if you have prostate cancer. And a biopsy is really where you go into a body part and take a small piece of it with typically a very fine needle, and take that piece, slice it up, put it under a microscope, and figure out if there's cancer in there or not. I will simplify this for you because there's a lot of information on the slide. If a cancer is found, it's important for you to understand the extent of the cancer, and that's in other words, it's called the stage of your cancer, and the biology of your cancer, which is oftentimes, we use something called the Gleason score. And Gleason score is where, as I said, the pathologist looks at the slides and says, hey, this clump of cancer cells is looking really abnormal. This is looking real different than what a normal prostate should look like. So your Gleason score is like 5, or Gleason grade is 5, and your score is like 8, 9, or 10. Or if it's looking like, hey, they're looking abnormal for sure, but they're not very abnormal, then your Gleason score may be 6 or 7. So that Gleason score plus how much of your prostate is involved. Is it one side, just a little bit? Is it both halves of your prostate gland? Is the cancer spilling outside of your prostate into the area around the prostate? Or has it gone to the lymph nodes, which are these tiny structures around the prostate gland? Has it gone to those lymph nodes, or has it gone to the bones, like far, far away? That helps determine what risk category you're in. So there's the prostate cancer risk category, which is low, intermediate, or high. And then the prostate cancer stage, which tends to be 1, 2, 3, or 4. Okay, so extent of disease and biology of disease, extremely important for prostate cancer. We use a lot of different, we can't open up a body to try to figure out where the cancer is spread. So we use a lot of different tests, including X-rays, CT scans, MRIs, and now PET scans. And that's to figure out how far the cancer is spread, the extent of spread, and hence the stage of your prostate cancer. And just to give you a sense, I mean, without making this too complicated, there's tremendous progress in this particular area. We're coming up with newer and newer ways to do imaging. And for example, about 2 months ago, FDA approved this brand new kind of a specialized kind of PET scan that is now able to pick up about 1 million cancer cells in one location. So it does a better job than the CAT scans and bone scans that we used to use. It's not available everywhere, but we're expecting, for example, at University of Minnesota, we're expecting this to be available in the next 3 to 4 month time frame. So more to come, but do ask your doctor if you are diagnosed with a high risk prostate cancer. You should at the minimum get a CT and a bone scan. That's available pretty much everywhere that does scans. Annie, are we getting any questions so far, or should I continue on?
I think you can continue on unless somebody has a question right now, but it doesn't look like we have any so far.
Okay, great. So either everybody is really listening in and I'm answering all their questions before they happen, or people are off to sleep after lunch.
I'm paying attention, so I think everyone else is too.
All right, fantastic. So we're about halfway through, and so let's switch gears. Let's talk about a guy who got diagnosed with prostate cancer, has gone through those scans, and now is sitting with their surgeon or with their medical oncologist and talking about treatment options. There's lots to go through here, because obviously one of the best things about, and one of the reasons why I'm so passionate about taking care of men with prostate cancer, is because not everybody needs treatment. And there are some who will really need everything I have to offer and then some. And so that whole spectrum of men who have prostate cancer, you have to care for them. So you have to know when to pull the trigger on treatment and when not to, and which treatment to use to make sure your patients live the longest possible with the best quality of life. So the goals of any treatment are, if you can, get rid of it, right? Cure it. If you can't cure it, then make people live the longest possible while managing their symptoms. So if you shrink the cancer in general, you improve the quality of life. So this is not, this is the story consistently in prostate cancer, where shrinking the cancer improves quality of life. That may not always be true for other cancer types. So when people hear about chemo and how their friend who had a bad lung cancer got real bad side effects from chemo and didn't really get benefit, that does not necessarily apply to men with prostate cancer. And it's important to recognize that. So the earlier the cancer is found, the smaller the cancer is, the more chance that we have of cutting it out or zapping it with radiation, trying to get rid of it, right? That makes intuitive sense. So low and intermediate risk prostate cancer in general is relatively straightforward to cure. It also as long as the cancer is localized, I think there is a decent possibility of cure. It's once it starts spreading outside the prostate gland to the lymph nodes or to the bone or to the lungs, at that point, we really can't say that there is a chance we will get rid of it. For a general patient, it may not hold true for every single one of them. I have a handful of folks who had advanced prostate cancer, metastatic prostate cancer, who are now in remission with an aggressive treatment approach. So that, that certainly can happen, but it's the exception, not the rule. I'm going to see, I think there are a couple of questions. Okay.
I answered it, I think.
All right, great. Thank you so much. I'm going to try to get rid of this. What's a Zoom meeting without having some technical issues, right? All right. So those are kind of, I actually, out of these 4 bullet points, I see 3 goals. Try to cure it. If you can't cure it, make people live longer and maximize their quality of life. So that's how I go about this with the people that I take care of. All right. So again, the reason why you need to see a prostate cancer expert is because of these nuances. When should you pull the trigger? How should you treat? And what the goals of the treatment are. So that's kind of summarized on this slide. There's a number of reasons why somebody, if you have a bad heart disease and you just had a heart attack like 3 months ago, well, your risk of a second heart attack within the next 2 years is pretty high. So that prostate surgery to take care of a local prostate cancer, which may not do anything to you for the next 5 years, that doesn't make a whole lot of sense. But if you're a 60-year-old who got a prostate cancer, that's probably gonna take you in the end if we don't get ahead of it. And so that's a situation where you really have to go all in and go all in fairly quickly. There are a number of options, and it really depends on what's your risk. So AUA risk, remember the low, intermediate, and high, and what's your stage? Is it 1, 2, 3, or 4? And that kind of combination determines where you fall on these options. For a subset of men who get diagnosed with prostate cancer, again, slow growing disease, not a whole lot of cancer, you may be recommended to undergo surveillance, meaning hold tight. And that's kind of the translation. Like, let's not try to cut this out because it may not do anything bad to you in the foreseeable future. And so surveillance takes, 2 different forms. You could actually just hold tight and forget about it and maybe do like PSA once a year or every 2 years or something like that. And that's called watchful waiting. The other approach is holding tight, but doing more frequent PSAs, more frequent rectal exams, biopsy maybe every year or so. And that's typically reserved for men who don't have an aggressive disease, but who really want to have a very close follow-up to make sure that doesn't change. And so that's called active surveillance. In terms of local options, radiation therapy is a very commonly used option. In localized prostate cancer, about half of the men in the United States end up getting radiation therapy. It can be given with seeds, so they are called brachytherapy seeds, and it's radioactive material that goes inside the prostate gland and kills the cancer with X-rays and radioactive energy. And then on the other hand, we can also put you in a big donut, and that donut has a number of kind of X-ray beams that get focused on your prostate from outside in. And that's another very commonly used modality. So that's called external beam radiation, because there's X-ray beams that are going from outside your body into the prostate gland. Sometimes we actually use radiation for men who have advanced prostate cancer, and that's to help decrease symptoms. So if you have one or two spots that are really hurting real bad, radiation can zap those spots and actually improve the pain. The other way to do this, if you have localized prostate cancer, is to cut it out. And when you cut it out, it's called prostatectomy, prostatectomy, which is to remove. And radical really only means that you take out the prostate gland, you take out the seminal vesicles that sit right behind it, and you take out the lymph nodes in from around the prostate gland. Your surgeon, depending on their expertise really matters. And your surgeon may actually use a robot, which is where there's a bunch of small holes, a few small holes that are put into your abdomen, and then the robot docks in it, and then your surgeon sits in a different room, or sometimes the same room, and kind of manipulates the robot. The benefit of that is you end up getting smaller holes and quicker recovery rather than cutting open the abdomen. Robotic surgery is not always possible, and those patients, open surgery is typically used. And then there are a few other options that are under investigation or uncommonly used. They include cryotherapy, where you take a needle and put in liquid nitrogen, and that freezes the cancer. And the same idea with HIFU, which uses either freezing or heating or electric current to kill or remove prostate tissue and prostate cancer. They're not really, they've not risen and met the standard which we use to replace them with surgery. They're just not as good as surgery just yet. If sometimes your doctor may recommend that you get hormonal therapy, and if that happens, it's called ADT. The interesting thing about prostate is, and prostate cancer, is it feeds on testosterone. So it takes testosterone from your bloodstream and sometimes makes its own supply of testosterone inside the cancer cell. So the first, and this is pretty cool because this goes back to 1940s when a couple of surgeons, they didn't have any options for men with bad prostate cancer who were hurting. So they thought, okay, if your testicles make testosterone, let's take them out and see what happens to prostate cancer. So they did that, and it dramatically shrunk prostate cancers. And that gave them a Nobel Prize in 1960. So pretty remarkable track record of this particular treatment. We don't typically take out the testicles anymore. We give a shot that shuts down the testosterone production, and there's that. Chemotherapy, again, as I've mentioned, I have guys in my waiting room probably every clinic visit or every clinic day. And if you see them, you would never be able to tell that they're on active chemotherapy. They don't look like those people you may have heard about who are throwing up in the middle of the night. Some of those men are actually surprised that they're doing so well. Not to minimize the treatment side effects, but there is a huge difference between what's portrayed as the side effects of chemotherapy and what my patients tend to experience. So talk to your doctor about this. If you're recommended to get chemotherapy, it may not be as bad as you think it will be. And because it's stop and go, we can always try it for a couple of rounds, and if it doesn't work for you, we back out. There are also a number of treatment options like in the pipeline, like immunotherapies or cancer vaccines, which are trying to stimulate your own immune system. So the exact opposite of chemo is your immune system is stimulated to go fight the cancer. So it's a really cool way to go about it. It just hasn't worked as well for everybody with prostate cancer. So more to come on that. I'm leading a national clinical trial through the NCI, National Cancer Institute, of 1,000 men. So one of the largest clinical trials in prostate cancer. And we're looking at making your cancer cells susceptible using a combination of treatments that damage the DNA. So there's a lot of really fascinating treatment options that are becoming available every year that goes by. So that's bringing me to the point of clinical trials. Again, going back to the point of why you should see a prostate cancer specialist is typically because they're, like I'm going to spend this morning through Monday morning just learning about from my peers and talking to them about what I'm doing. But that keeps us attuned to all of the landscape of what's going to come through for our patients in the next year, in the next 2 years, and it helps make a long-term strategy for folks like you. So talk to your doctor about clinical trial. It's to give you access to something that may be really, really good treatment option, but that's still under investigation. And it may work for you, it may not work, but at least you would have had a conversation about it. You can go to clinicaltrials.gov. It's a free website, and you can find some treatment options there too. So there are anything that cures cancer or treats cancer comes with side effects. So if you're not getting side effects from your treatments, you're probably not getting an effective treatment. That's kind of the way I think about it. And I don't mean like bad side effects. I mean, at least some side effects. Like if you come out of surgery, you're hurting, right? That's a side effect. It's manageable, and it's maybe a very small amount of pain, but it is a side effect. So if somebody comes to you and says, hey, here's this pouch with, a brown color powder that's really going to work awesome for you and give me $500 for it. And if you don't get any side effects, probably didn't work. So think about that. There are really good ways to control and treat most, if not all, of the side effects that people experience. We may not be able to get down to where you were when you were 40 years old and running marathons, but we should be able to make your life better enough where you can go about it without worrying about these side effects on an hour-to-hour basis. If your prostate cancer gets to a point where it's really advanced or progressing really fast, you may benefit from seeing palliative care experts. And they help with symptom management, and it's a group of people who support not only you, but also your family and your caregivers with that extra layer of somebody you can reach out to in the middle of the night if you need help. They also help plan ahead. So if all you got left is a few months or a short number of years, they can help, plan ahead for that. So I'm sure that this is a lot of information for most of you. No matter where you are in the spectrum, this is a lot of information, and it may overwhelm you and us as you make these decisions. So there are, as I've said, leverage that community. There are so many people who've dedicated their lives to helping men with prostate cancer and families of men with prostate cancer and caregivers of men with prostate cancer. There's a big network out there that's working just for you. Leverage that network. One of those options is this program called Open to Options, which is, I'm not affiliated with this, but it seems like a good resource. It's a decision support program that can help you prepare. And I think there is a way to interact with them. But if you need more information, that's the number to call. Personally, me and my team have been very unhappy with the state of affairs when it comes to taking care of men with prostate cancer, and just communicating all of their options, because there's so many. There's so many options. And if you do a Google search, your head would spin in circles, because there are so many things that can go and kill prostate cancer. Is that applicable to you? Is that new treatment that just got FDA approved? Are you a candidate for that treatment? It's hard to figure that out. it's hard to keep track of all that. So we said about a year or two ago, we said enough's enough. We need to help our patients do better with their education, with the navigation as they go through the cancer journey. We need to have something available for them in the middle of the night if they need help. And so our group created this free to use app called Ankr. And the kind of the unique part about this is it makes things relevant for you. And it avoids those Google searches and those anxiety with Facebook posts and so on. It uses something called artificial intelligence, which is a really cool way to leverage computer power and machine learning and so on and so forth to simplify things for you. So once you enter where the cancer started and what stage you have, it'll give you only the relevant treatment options. It'll help you with recording audio of your visits, simple things that make your life just a tad bit better. So if you're interested, you're welcome to go to ankr.us/download to get this app on your phone, free to use, and give us some feedback while you're at it. And this is not affiliated with Gilda's Club, but I thought that this may be a good resource for some of you out there. All right, so your healthcare team, and I think this may be the last few slides that we have, but there's a lot of different types of doctors that you may see: a urologist, which is a surgeon, an oncologist, which is somebody like me who gives chemotherapy or hormonal therapy or other treatment options, and then a radiologist or a radiation oncologist. And all those people are really trying to give you their perspective on your situation and help you make a decision. Always, half of or a quarter of my practice is men with prostate cancer who come to me for a second opinion from all around the country. They fly in with their records, get the second opinion, then fly out, and fly out with the piece that whatever treatment they're getting or whatever I'm recommending is a really good treatment option for them. So always consider getting a second opinion. So this slide kind of summarizes some of the questions you should be asking, and you'll have a copy of this slide, but talk about what treatment options you have, the side effects, how should your family and friends go about supporting you, and what can you do to stay healthy as you go through these treatments. A lot of people ask me a lot of questions about supplements, and there are waves of when everybody wants to do keto diet to get ahead of the cancer because they read that cancer feeds on sugar. And then there are waves when everybody wants to get pomegranate juice or whatever. So there are a lot of these health trends that you may not want to get caught up with. The bottom line is, as long as you have a healthy, balanced diet, so you're not eating a steak a day nonstop, as long as that's not happening, I think you'll be fine. Quit smoking. That's a big risk factor for bad outcomes, for bad juju. It stimulates the cancer in a variety of different ways, and you really don't want to go there. There are lots of assistance for men who are unable to stop smoking by themselves. You have a lot of resources. Just ask your health team. If you are worried about risk of prostate cancer, consider getting screened. Talk to your primary doctor about it. Tap into that support group. If you know somebody with prostate cancer who's been there, talk to them, and make sure you keep your appointments. Right? If you may be tempted to just say, "I'm not going to worry about this. This may not cause me any harm." Just do that with medical recommendation and with proper oversight. And men are, we're really not very good about talking about our feelings. And I'm not asking you to fundamentally change who you are, but do debrief, do let go of some of that stress. Stress is bad for a cancer journey, and people around you need to know why you're stressed to kind of come in the way of that and help you out with it. So ask for support. we already talked about this, but so I'm going to skip this slide to give us a little bit more time. There are a number of resources. This is a list of them. And then you're always welcome to reach out if you have questions. Not necessarily to come see me in the clinic, but if you have any questions that I can help answer, happy to do so. And with that, thank you so much for your attention. I'll open this up for a discussion with our attendees.